medir y cómo mejorar los resultados de la prostatectomía radical. Derya, we are very pleased to be with you today. Yeah.
Thank you very much for the kind introduction, and thank you very much for this great invitation to this fantastic city, my first time in San Sebastian. So, can you bring up my slides, please? Oh, yeah. Okay, so I have no disclosures with regards to this talk. I will start with introducing the Martini Clinic Prostate Cancer Center as an example for a high-volume center. I will discuss the importance of volume for outcomes, and I will introduce the benefits of a database and outcomes measurement in general. This is the Martini Clinic Prostate Cancer Center in Hamburg, was founded in 2005. It is the only European institution exclusively dedicated to prostate cancer diagnosis and treatment, and it is located at the campus of the university hospital. So since founding of Martini Clinic in 2005, the number of surgeries steadily increased, last to 2,500 in 2018. And we do more and more robotic surgery. About 40% of the surgeries are still open in our department, and 60% are robotic approaches. With regards to academic prostate cancer centers, we are also the highest volume in prostatectomies, also compared to US centers such as Mayo Clinic, Johns Hopkins, or Memorial Sloan Kettering. What are the characteristics of the Martini Clinic, which is actually very young, only 14 years old? What makes it so successful? There are three important points to this. I think one is the specialization. So the Martini Clinic is basically an integrated practice unit. What does that mean? It offers the whole spectrum from diagnosis using all types of imaging to local treatment, not only a radical prostatectomy, but also radiotherapy, focal therapy, active surveillance, and also treatment of metastatic prostate cancer, including newer agents. We have a dedicated medical oncologist working in the Martini Clinic. Also, we have a psycho-oncology team and a nutritional medicine team. So this is called an integrated practice unit. We have a faculty system, so we are 12 surgeons. Each patient has only one contact person, his surgeon. All are high-volume surgeons performing 200 to 300 radical prostatectomies per year, and all of the surgeons have a special scientific field of interest. In addition, this is just for example, some of us focus on focal therapy or imaging, while others focus on robotic surgery or outcomes research, tumor markers. The last person who joined our group, he focuses on radio-guided surgery after radical prostatectomy. While in Germany, and I don't know if it's true for Spain, but at least for Germany and Italy, for example, I know there's a lot of hierarchy in hospitals. We don't have this system. Our system is more similar to the US or maybe the UK, where we have an equal faculty system and all of the surgeons are independent. We also have an associate faculty, so we have the responsible team leaders part of the Martini Clinic. There's the anesthesiology, the pathology, radiation treatment. The radiology, we have our own radiologist. He exclusively works for the Martini Clinic. And we have our psycho-oncology team. So as Paul also mentioned, it has been shown in multiple studies that high volume is key for improving in-hospital outcomes. This is, for example, a study which showed it for Germany, but there are also a lot of studies from Andrew Vickers and this group on this topic. Here's a study, for example, showing that even after more than 1,000 total prostatectomies, surgical and oncological outcomes of individual surgeons are improving. And this is measured, for example, by the percentage of positive surgical margins or 5-year probability of recurrence. Despite the fact that it's known that surgical volume influences outcomes, this is a table for Germany. It shows the red thing is the Martini Clinic, but more than 50% of all radical prostatectomies in Germany were done in hospitals with less than 50 radical prostatectomies per year. The third thing, and that is probably the heart of the Martini Clinic, is its database and outcome measurement. So what happens with the patient? Did I help him with my treatment? What's his quality of life? To answer this question, we have to ask the patients. We are sending out more than 20,000 questionnaires per year. This is patient-reported outcome measurements, prompts. We do this pre-operatively with validated questionnaires, 1 week after the surgery, 6 months after surgery, and yearly. So this database started not with the foundation of the Martini Clinic, but before, in '92, because the founder of the Martini Clinic, Professor Huland, he was the department chair of the Department of Urology of the University Hospital Hamburg, and he started the database already in '92, as said. So we have outcomes data from more than 28,000 patients. After prostate cancer treatment up till now, we have profound preoperative data from each patient and his tumor characteristics. What are the advantages of outcome measurement? I will go over the next 4. So first is the quality control, and we heard about this already in the previous talk by Paul. So we can provide quality assurance. We can look at nerve sparing rates, positive margin rates between the different surgeons and discuss them. We are also, as a team, meeting every 6 months and discuss our results. So also we see oncological results in total. The first plot shows it stage dependent. The second one dependent on Capra surgical score. And this is, for example, the result of one of the 6 months meetings a few years ago. So when looking at continence 1 week after removal of the catheter, we observed similar continence rates, except for 1 or 2 surgeons who were better than the other ones. So similar also to the procedure in the UK. We analyzed what these surgeons were doing differently, and the urethral length is very important in this context. So we realized that these surgeons were doing individual adapted intraprostatic apex preparation to achieve the full functional length urethral sphincter preservation. And this was not done by all of the surgeons, because normally you would do the dissection here at the end of the prostate, but you would not probably aggressively go apically. So once this technique was introduced into all surgeons, so all were doing it, if of course oncologically possible, we saw a clear increase in 1 week continence rates after this technique. So our 6 monthly meeting allow that we learn from each other. And not only that the that the younger ones learn from the older ones, but sometimes it's even the opposite, and the culture is similar to what Paul described. So this way we also achieve excellent outcomes. This is a study by an insurance company in Germany showing that all results in all hospitals together in Germany for 1 year full continence were pretty poor at 56%, while Martini Clinic was achieving rates of more than 90%. So this is very interesting to see this huge difference in outcomes through volume and steady quality assurance. The second thing is patient counseling. So patients want to know what they have to expect, and they actually don't want to know what they have to expect in general when they are operated anyway, but they want to have the results of the hospital who's performing the surgery. So we regularly publish on our results. This is just an example on short and long-term functional outcomes and quality of life after radical prostatectomy. And we clearly can tell our patients, okay, after 3 months after surgery, you have a likelihood of 75% to be continent. Also, we can tell them that even if they have bilateral nerve sparing, only 55% of the patients have erectile function again after 12 months. So we can provide pretty exact estimates. Also, we can individually adjust that, and this is a study showing the effect of age on functional outcomes after radical prostatectomy, were clearly seen and has been shown in many studies that with increasing age, for example, above 70, the probability of continence at 1 year decreases significantly, and this is more significant also for erectile function rate. We tell our patients above 70 that they have only a likelihood of 35% to recover erectile function, even if both nerves have been spared. So it helps to have the right expectations of the patients. And if you don't measure your own results, you would only be able to cite results of other hospitals. Next to this, the database allows us a lot of clinical research. So the number of publications is about 80 to 90 every year. Only these are publications including results from the Martini Clinic database. And I will show you one example, and only a database like this will allow answering these questions. This is an example about a never-ending debate if radical prostatectomy is better than robotic surgery. So, and what is unique of the database that it includes data of multiple high-volume surgeons who perform both robotic and open radical prostatectomy in a high volume. So this was the last study we published in BJUI. More than 10,000 patients. The patients were propensity score matched, and we basically showed that there was no difference in biochemical recurrence rates between both approaches. With regards to urinary continence, we found something interesting. The urinary continence at 1 week was better for the open approach. We think the reason for this is that we use interrupted suturing for the anastomosis in the open approach versus continuous for the robotic approach, which may have more injury to the sphincter in the beginning. But after 3 months, continence rates are similar at 3 months between both approaches. At 1 year, we saw a slight advantage for the robotic approach, but when 1 year continence rates were evaluated across age groups, no statistically significant differences were observed. What about 1 year potency? There was no difference in our patient cohort with regards to potency. But when we published our data on post-operative complications after open versus robotic surgery, we saw that the open approach was associated with a higher rate of major Clavian grade complications. So in conclusion for this question, we answered with the help of a database, is that there were significantly better continence rates at 1 week in patients who underwent open radical prostatectomy in a retrospective study with multiple high-volume surgeons. Of course, surgeon experience rather than the technique used is likely to affect outcomes. Independent of approach, it is best to refer to a large volume hospital. And open radical prostatectomy remains an excellent approach. However, in these patients, I do prefer robotic surgery. So, last, the basic science is also something which can be done by having a database. We are one of the only German institutes for the prostate cancer initiative of the International Cancer Genome Consortium. And this is possible because we have huge prostate cancer tissue microarrays, including more than 10,000 patients. And via the database we have since '92, we can correlate tissue data with long-term oncological outcomes. So some ideas to establish the general outcome measurement in healthcare system is to offer certification for centers, to also base outcome measurement on, or base reimbursement on outcome measurement. So not the number of cases should count, but the quality counts. And outcome measurement should be transparently reported, for example, on websites where patients, physicians, health insurance companies can look them up. Because we have this example of the Martini Clinic, which is actually a very young hospital, Michael Porter, a Harvard Business School professor who is very well known in value-based healthcare system studies, he defines value as patient health outcomes achieved versus cost of delivering those outcomes. So he chose the Martini Clinic as a case study for his students. So every student who attends the Harvard Business School has to study the history of the Martini Clinic, which we are very proud of. Michael Porter is also the initiator of the International Consortium of Health Outcomes Measurement, and they have initiated the creation of a standard set of outcomes which should be measured and published it. And the main person responsible for the standard set for localized prostate cancer was Hartwig Kuland, the founder of the Martini Clinic. So he summarized only outcome data which matter for the patients and that it can be standardized across different hospitals and allows better comparison between hospitals. This study was shown by Paul a few minutes ago. So it basically summarizes also my talk. In summary, the benefits of quality assurance are undisputed, also shown in the previous talk. Effective quality assurance requires centralized care in high-volume institutions. The existing examples confirm that centralization of care and measurement of outcomes significantly improve patient outcomes within a short period of time. And in this editorial, we even wrote that we doubt that it is ethical to keep on going as we have done for decades, letting elective surgery be performed regardless of quality standards and quality control. Thank you.